Is anyone in the room feeling anxious? Anyone feeling anxious? Okay, I have to raise my hand. And I do a fair amount of speaking. I was thinking this morning, why am I feeling anxious about speaking to this group? And I think it's all about integrated care. Because quite frankly, I mean, how many medical providers are in the room? Yeah, none. Oh, we got one. We got a brave soul. Are you feeling anxious? Yeah, there you go. She's feeling it out. It's sort of like a Democrat going to a group of Republicans because they want to talk, and understand each other, and like you feel like kind of anxious because you're the one in the room. I think the fear of this is because I'm coming from a medical perspective, but that's exactly why they asked me to come and speak here, which is we need to understand each other. And so I'm sure I will, an easy thing is for you to kind of turn off, because, well, what does he know, because he's a medical provider versus he doesn't really understand behavioral health. But that is exactly the problem, and that's one of the things we have to resolve, and you're going to sort of hear about that as we talk today about we together need to integrate for many reasons, but mostly for the benefit of our population. So just to give you a little of my background, I went to medical school because I really wanted to work in a medically underserved area. I went to the University of Illinois. While I was there as a medical student, I started realizing, because it served very much an underserved population in the west side of Chicago. And what I saw repeatedly was frustration on the part of the residents and the attendings because their patients were non-compliant. And a lot of patient blaming. And so I started to realize, they really didn't understand, and they didn't understand what the barriers that their patients were facing in terms of complying with their treatment plans. So I started to attend a church on the west side of Chicago, North Lawndale. North Lawndale is the community when Martin Luther King came north in the mid-'60s to demonstrate that there was housing discrimination. He lived in North Lawndale for over 6 months. That community all the commercial strips in that community were burned down in '68 with the riots. And by the time I was going to medical school, which I started in 1979, they had not been rebuilt. So I started to attend the church and started to realize that, what I didn't really understand. I'd grown up in an upper middle class white community. What did I really understand about the population? And then to the extent that I knew that if I was going to be effective, because as I started to go to that church actually decided it wanted to start a health center. We put up a blackboard one Sunday morning and said, what are the needs in our community? We need to meet the needs of our community. The first thing was for a safe place for laundry, because the gangs had taken over the laundromats. So the first thing we did was got used washers and dryers and put them in the church. But the second thing was affordable health care. Because if you're uninsured and poor in Chicago in 1978, you could go to Cook County's emergency room where they would diagnose your heart failure, your diabetes, whatever, but there was a 6-month waiting list and you were part of the system to get into the clinic system. So that kind of went up on the board. They all kind of looked at me. I'm a fourth-year medical student. Going, no. But the more we kind of prayed about it, we realized, that's probably what we should be doing. But we realized that if we were going to be effective, we need to move into the community. And so we moved into North Lawndale, and I lived there for 34 years. And that was the most important part of my education. Yes, it was important. I learned how to learn medicine. But my education really came from my neighbors and being part of that community. And that's when we started to understand the role of social determinants of health, the importance of behavioral health, as well as good access to medical care services to improve population health, which is what I'm going to talk quite a bit about today, is how do we improve the health of the population that we jointly serve. So my experience with behavioral health services is when we opened our health center in 1984, was that behavioral health was paid for by a separate agency. It was not paid for by Medicaid. That in fact I could not hire a behavioral health provider because it was not a reimbursable service. If any of you were old enough as me to remember that even many commercial plans didn't cover behavioral services as something that was reimbursable. And so my experience with behavioral health is that I would get a piece of paper, usually on a prescription pad, from a behavioral health provider from the community mental health center saying, could you draw these labs and send me back the results? So that was the degree of integration of behavioral health back in the mid-'80s. We got involved with value-based payment as a health center back in 1987. And so one of the first things we did was realize that we needed to provide behavioral health services. And so even though they weren't reimbursable, we added behavioral health and counseling services because we thought it was really important. And not that I wouldn't refer to the community mental health center, but quite frankly, there was no communication. I had no idea what was happening there. it really wasn't informing my care. And so we started to add behavioral services. Fortunately, Medicaid kind of advanced to where, at least in Illinois, they started to reimburse for behavioral services. But the behavioral integration stopped at that point. We did warm handoffs, we did short intervention, but we knew that there were patients that needed more than just those short interventions that are pretty commonly done in places like federally qualified health centers. And again, the integration was really not there. It really wasn't until I left the health center after 27 years in 2011, and we started a great medical home network, that we started to realize that because we were responsible for the population health and for the total cost of that population, is that we needed to be really close partners with our community mental health centers. We brought them around the table. We understood that although we were delegated for care management, the care management was done at the practice level, which I think is still the most effective way, quite frankly, to be able to take advantage of having the care manager there in the medical home, to build a face-to-face trusted relationship with that patient. I think that's really important. But we realized there was a segment of our population that was not walking into the primary care practice, and that we really needed trained behavioral health care managers that were facing at the community level to interact with them. And so we started to integrate, and so I think my experience that I'll share with you today is kind of that pathway of going from where there was really totally non-integration to really moving towards increase. But we haven't gotten there. It's still a strong pathway. Quite frankly, when we talk about integration, we talk about physical health and behavioral health integration, but even within physical health, the system is not integrated. I mean, I'm sure, and there's probably nobody in the room that doesn't either themselves or have a family member or friend that has complex medical problems that are seeing multiple specialists. My best friend is actually dying from advanced prostate cancer, and he sees multiple types of specialists. They don't talk to each other, even though they're in the same system. They're all part of Northwestern, okay? But the oncologist, the radiation therapist, the neurologist, you go down the line, all the different specialists that he sees, and he gets really frustrated. He goes to see him and realizes that nobody actually, even though they're on the same EHR, they're not looking at each other's notes, and it's not an integrated experience. So we have a long way to go in terms of integration. I think you probably have the same experience when one of your patients gets hospitalized. And inpatient psychiatrists may change their medication therapy and change their therapeutic plan, and then they're discharged and you don't get the records, or you're really not sure what happened to them, and they show up and they have a kind of a vague idea what happened to them as well. So if we're going to improve the individual care, then we have to be more integrated. But I think what I want to talk quite a bit about today is if we're going to take a population health approach to integration, is that we have to go beyond the individual patient, because we all know that there are patients that are suffering from conditions, whether it's behavioral health conditions or physical health conditions, that are not coming and getting care at all. And they're showing up in the emergency room, they're sometimes showing up in a hospital. You kind of get this idea, well, you should follow up on them, but they never show back up. And it's like, well, I'm busy enough with the people that decide to walk through my front door. I'm going to really concentrate on doing a good job for them. But from a population health standpoint, we will continue to fail our population unless we understand that it is our accountability and responsibility to take care of the entire population, whether they decide to take the initiative to walk through our front door or not. So that's just a little bit of background. So we're going to talk a little bit about how we take a population health approach and how we need to do that from an integrated standpoint. Integrated in terms of, yes, we as behavioral health providers with physical health providers, but also in terms of integration with community-based organizations to really take a culturally appropriate route, because we increasingly are realizing that population health is very much about improving and addressing social drivers of health as well. We're going to talk about how, at least from a behavioral perspective, how we take a relatively narrow view on how we measure whether we're being successful in that or not, and so we'll talk a little bit about that. But we're going to move towards value-based payments. As Jean mentioned, our system has moved off in Chicago, where I work. We've moved off of a fee-for-service system. Our primary care providers are paid on a capitated basis, and they are responsible for total cost of care. It now gives me the flexibility to sort of say, you know what, I don't have to limit my behavioral services to just treating people once they've gotten a more advanced condition, is what do I need to do from a prevention standpoint? So the health center that I was at decided that, you know what, yes, it needed to start a medical clinic, but it also started housing, it started a legal aid clinic, it started a development corporation that developed job development. We started a fitness center. We got tired of telling people, you know what, you need to go and exercise, and there was no safe place in our neighborhood to go and exercise. We started a cafe where there was a healthy food option. We started a program for men that were transitioning out of prison or trying to transition off the streets from a gang culture. So if you're going to take if we're really going to improve health, it's really going to require us to take a holistic approach to population health to do so. So I'm going to do that, and we're going to talk about clinically integrated networks and where that fits in terms of behavioral health providers as well.
Hey, Art. I'm going to
Yes.
pause for just a second. We're having trouble hearing in the back, so now we can discuss how.
Okay.
Is this any better, guys? We're hearing? Better? Okay. So try this, and if we're still having trouble.
Yeah, Art. And I'm going to ask the people in the back, if you have trouble hearing, just stand up. And I'll see you stand.
You don't have to stand up, just raise your hand, and I
If
will.
you can't hear, just, we want to be able to hear, so stand up if you can't
Okay.
hear. And we'll take a Thank you.
I won't repeat all that. So I think our healthcare system is the best in the world once you get sick. As we realize it's not one of the better in the world in terms of preventing us from getting sick at the beginning. Yeah, we still can't. One, two, three, better?
Yeah, I really do, Justin, it's not great back here.
Yeah. The neurosurgeon managed to clip my recurrent laryngeal nerve, so I do not project that now.
Is this better or worse? Okay. Here we go. Much better. There. It's turning it the wrong way. There we go.
Okay. And I can now. I can actually, oh, that's really good. All right. If it gets too loud, just give me the thumbs down. I'll interpret that correctly. So I think what we've started to do a much better job is to understand population health beyond just the individual patient, and beyond the simple quality metrics that we are currently following to start to look much more deeply on a multifactorial basis to understand our population. So part of that has to do with really population health science, and really aggregating multiple sources of data. We're going to talk about that. But then also, what are the plans? What do we need to do differently? I think we all have gotten this as providers, whether behavioral health or physical health. We're kind of used to, hey, this is the way we manage our patients. This is how we've been successful, and particularly this is how we get reimbursed under a fee-for-service system. But how do we take a different approach and understand our opportunities to improve the health of our population? And how do we change the incentive system and reimbursement system? Because quite frankly, you still have to, your checks still have to be able to be cashed for your staff. We still have to make things work financially, but we also have to look to see what do we need to do differently, and what's the financial sustainability approach to be able to do that. So I think we all realize that it's not just that it really is a combination, as Josh talked about, in terms of physical health, behavioral and emotional health, and social health. So I think we're pretty familiar with physical health in terms of preventive services, kind of understanding risk factors. I think we're starting to understand much better from behavioral health in terms of what that preventive, which is really emotional health. It's really kind of identifying what are the things that if we don't deal with right now from an emotional health standpoint, that are going to lead to some of those behavioral health conditions down the road. And how do we identify those that are in that rising risk population from a behavioral health standpoint? So we all kind of take a look at our data in terms of our adolescents and the rising incidence of depression, and what are the things that are the emotional things that lead to, if unaddressed, whether it's bullying, whether it's the social media, what are the things that we need to be able to identify, so we're not waiting until the fact that they come into your office because now they have a behavioral health condition. So it's really about, can we keep our patients healthy, both physically, from physical health and from a behavioral perspective? Can we identify those that have an emerging risk? Can we manage across the continuum of care? By that I mean, can we really integrate with our physical health providers? And can we really take can we really manage our patients that have multiple conditions, particularly those that have both medical, physical, and behavioral health comorbidities? So how do we do that? I think the first is that we need to collect the information, and then we need to analyze the information to understand the population. We do not do this very well. I mean, I think one of the promises potentially for managed care is that because they now start to both increasingly pay for more of the services that you provide, is that they have more information. But what do we do with that information? And is it really being integrated and analyzed? Because for us to identify the rising risk emerging population is we've got to be able to take multiple sources of data in real time and analyze it to identify the populations and the interventions that are going to be most helpful. Can we segment that population in terms of risk stratification? So risk stratification right now is largely built upon claims data, and it's built upon conditions. But if we're saying that social determinants of health that are an important part, then how does that get integrated into segmenting our population? Then we need to really plan the intervention differently. And too often, as is evidence again in this room today, is that we don't plan together. And in fact, it's nice that I know the managed care companies are here today, but often the planning gets done at the managed care level. They have their own groups that are looking at their data and understanding it. They're coming up with some interventions. Behavioral health are looking at their limited set of data. Physical health is looking at their limited set of data. The social drivers of health and care management information sitting in the health plan, it's not integrated, and it's not being shared, and we're not jointly planning together about how we're going to improve the population that we serve. So it really comes down to us looking at both the population, the data from a population perspective as well as from an individual perspective. The data that we do needs to be data-driven, and so the information that we do and needs to be informed by the data. Too often we as providers, and we're actually seeing the patient, the data doesn't come to us at the time of decision making, and so we make decisions without really having all the information available right at the time. I think we're making improvement with that in terms of our electronic health records, and also in terms of interoperability of sharing information. The approaches we need to take need to be evidence-based to the extent that there is evidence that is there. But there's a lot of things that are not evidence-based. And so I think we need to learn what we can, and we need to be innovative and try new models, and be willing to go beyond and say, well, we're going to try this because it makes sense to us based on the information that we see. But we need to then measure the outcomes and turn it into evidence-based interventions. We really need to address health equity. So I think that health equity is not about treating everybody equally. It's about understanding what it takes for each of our members in our population to really maximize their health status. So that means that we need to use risk stratification to say which of our patients need a particular intervention that maybe the rest of the population or most of the population doesn't. That really is health equity. That's about, in terms of managed care, it's about identifying who's going to most benefit from high-risk care management and provide those additional resources for them as well. It's really then working with plans and partners together. So I would urge the health plans in the room to develop multidisciplinary groups of providers that are looking together at the data that they have and coming up with what it takes for us to improve the health of our population, that it needs to be information sharing. And then we need to change the incentive system. Our incentive system needs to be aligned across our delivery system with the goal for us to improve patient outcomes. And we're going to move it progressively away from simple process type metrics to really patient outcomes. What's most revealing in terms of predicting what a patient's outcome is going to be is to ask them how do they feel their health status is. Is it excellent, good, fair, or poor? It's a really simple question to ask, but the data really shows that it's really pretty predictive of who's going to be expensive going forward. And ultimately, shouldn't that really be the most important metric? That we have a group of patients that are attributed to us and say, you know, my health status is not very good, and to be able to track that serially and for them to be saying, you know what, my health status is improving. So I think we need to look at, and we need to incentivize our providers to improve the way that the patients feel about their health, as well as some of the other quality metrics that we're using. So we take a general population, and managed care organizations are assigned the general Medicaid population. So basically in DC, almost all the Medicaid beneficiaries are in managed care, as is true now in most states. But there is a segment of that population that you as behavioral health providers are responsible for. And I think that really is a challenge when it comes to behavioral health. So what's happening in physical health is that every member within a managed care company is assigned a PCP. Either they choose a PCP or they are auto-assigned a PCP. So everyone knows, you know, this is their PCP. Okay, whether the patients go there or not, and physical health providers will complain about, you know, you're holding me accountable for patients that are not, for individuals that are not really my patients. Well, yeah, that's the challenge, so step up, okay? But when it comes to behavioral health, it's much more challenging because they don't choose a behavioral health provider. And so you're starting to see, and I was happy to see, I spoke with one of the managed care companies in DC in preparation for this talk, is that they're starting to move towards attribution. I'm going to show a slide later on to sort of say, well, where have they been going for their behavioral health? But I think even a challenge beyond that is, what about the individuals that have a behavioral health condition that really is a driving factor in their overall health status, that are not going to see one of you as a behavioral health provider? How do we make somebody accountable for them as well? And then once you have a group of patients that are attributed to you as a behavioral health provider, based upon, hey, they've been going to you historically and getting most of their behavioral services from you, how do I identify those individuals within that group that need a special intervention or special attention? So you do that by, I think, combining several data. So there's data at the population level. So we know that if you happen to live in North Lawndale, like I did, that there's certain factors by living in North Lawndale that contribute to my overall health status. Again, things like the lack of a place to go and exercise was certainly a factor. The school system was a factor. The safety and the violence in our community was a factor. So there's certain things that impact me, just like they impact everyone else living in North Lawndale at that time. But then there's also within that, I never pretended that everyone on my same block had the same social determinants of health as I did. They clearly didn't. And so it's important to be able to combine that population health level by doing health risk assessments, including social drivers of health. So we really need to understand at the individual patient level. Our experience back in Chicago is, so Illinois requires that the health plans do a health risk assessment, including SDOH screening, within the first 60 days of enrollment. Well, quite frankly, the compliance with that is way less than 50%, except for Medical Home Network, where we work, because all the care management is delegated down to us. So guess what? We get about 85% compliance with that. Well, why is that? Because when the phone rings and you look on the phone and it's a stranger, how many people pick up the phone when they look on there and you don't recognize the phone? There's always somebody in the crowd, come on. So either do our patients, right? On the other hand, if they pick up and they recognize this is my provider, whether it's behavioral health provider or a physical health provider, they tend to pick up, hey, my doctor's office is coming. So when that call, and then they pick it up and they say, you know, they identify themselves as the community health worker working with that home, medical or behavioral health home, and they say, can you spend 5 minutes, we want to ask you these questions. Guess what? They tend to answer the questions. So it becomes really important that we get that data, and then what do we do with that data? And that's what I'm going to show you in terms of analysis. Because first of all, what you should be doing with the data is identifying, hey, here's a barrier, and I need to be able to make a referral. So I think increasingly we're having electronic registries, as we do in Chicago, to sort of say, well, here's the appropriate CBO in their community that deals with this issue. But do we ever go back then to rescreen the patients? It's kind of like saying, you know, well, we're going to screen for depression, and we're going to do a PHQ-9, but do we go back after we've been treating them for a while, increasingly we're going back to repeat the PHQ-9? You know, if they have hypertension, we're going back and repeating their blood pressure. If they have diabetes, we're repeating the hemoglobin A1C. Well, when are we going to start repeating their SDOH screening to say, you know what, we recognize that these factors are really important. Are we actually improving this? And so that's what we've started to do within within our ACO is to say it's not enough to just identify. It's not enough just to identify and to refer. It really needs to be, do these refer? And now we started to build electronic registry and communication between those community-based organizations. So not only do we have that with behavioral health providers and medical providers, but we have with the CBOs as well. So it's all about us kind of taking that personal information and making sure that we're addressing it, but then incorporating it into our analytics to identify what do we need to do different from a population health standpoint. And then the other thing is, is claims data. So claims data is interesting. So it's really hard for providers to get claims data, and there's lots of reasons why, whether it was before they went to managed care or even after they went to managed care. What the managed care companies will often do for you is they will provide you with reports. But the reports tend to be kind of high level. If you go to them and say, just like if you went to the state and sort of said, well, I really want you to run this report because it'll give me additional insight into how I can improve the population, they say, well, I really don't have the ability or time or resources to do these customized reports. So what we've been able to do with our ACO is be able to get claims data from the MCOs. And once you start to do that claims data and you start to bring people around the table, and they start saying, well, I see this. Can you run the data this way, slice and dice the data this way, and gradually keep doing that in a serial fashion until finally you start to understand the population. So I'll give you an example, is that we looked at our data to say where within our ACO, where was the group that had the highest 30-day readmission rate? Anyone want to guess what condition led to the highest 30-day readmission rate? It was behavioral health, right? It was schizophrenia, bipolar, SUD. You looked at 30-day readmission rate. It was, okay, we're clearly failing the population. I mean, if someone gets admitted for one of those conditions, and heart failure got in there, and I'm not saying it was all behavioral health, but the top three were all behavioral health conditions. If we're admitting somebody to the hospital for one of those conditions, they're back in 30 days, something's not right? Okay, we clearly are not addressing their issues. So we said, well, okay, so let's focus that. Do we understand? So we started to look at what the pattern of utilization was up to the time of admission. And we looked at what their utilization was for primary care, for seeing a behavioral health provider, for their medication, whether they're filling medications or not. We looked at what their patterns were, and then we looked at their pattern after they were discharged from the hospital. And we saw that, 50% of the people that were being discharged for a severe mental illness were not going to the pharmacy in the first 30 days. And then you start to see what's happening further down. Well, did the behavioral providers know that they were not taking the medicine? So listen, I worked primary care for 27 years. I asked the patient taking the medicine, what are they going to say? Yeah, of course I'm taking the medicine. So I finally got to say, okay, you got to bring your bottles in, okay? And so then I started looking at the dates on the bottles, and I realized, okay, it's been 3 months. So someone got smart. They kind of say, you know what? I think the medicine, my new bottle's important than the old bottles. That's what I'm saying. And if you believe that, I'll sell you a used car too, right? But do we as physical health providers or behavioral providers have a good feeling to understand that my patient's really taking the medicine? And there may be very good reasons why they're not taking the medicine. It might be an affordability issue. It might be that they don't understand. It might be, most likely is they're not feeling very good. I treat a lot of people with hypertension. They felt really good till I put them on a hypertension. Their blood pressure's high, but they're feeling fine. Okay? And then I put them on a blood pressure medicine, they become impotent, they become a little drowsy. Well, it's the same with the behavioral medicines as well. A lot of times people don't feel very well. Well then, if we don't, but they come and tell me I'm taking the medicine. If I don't have that information, I make mistakes. What I kept doing for hypertension is I kept escalating the medicine. And you may be doing the same thing for behavioral health, but keep switching the medicine when really they're never taking it in the first place. So it's really about us getting the claims information. Well, guess what? Pharmacists are really good about submitting claims. None of this claims delay stuff, okay? When you fill your medicine, they bill it right then. The information is available. So we started getting information the very next day. So it's never more than 24 hours delay. So if someone was discharged from a hospital, our care managers know, hey, I discharged them from pneumonia. Did they actually go fill their antibiotic? Well, we started looking at our behavioral health data, and the medicines weren't getting taken. We were surprised. They thought, well, we referred them to the community mental health center for follow-up for their SMI, but they weren't actually showing up. And again, it was dropping as well. So we started saying what we really need the intervention is that we need to engage those patients during the hospital. Because what would happen is we would say to our community mental health centers, well, you know, this patient was hospitalized, I need you to reach out and follow up with them. Well, they'd be discharged. So you get a list of these are the patients I want you to follow up with. And so they really didn't know what happened in the hospital. And guess what happened when they tried to follow up with them? We all know, like the phone numbers were wrong, right? So, or even if the phone number was wrong, again, that patient's looking at that and kind of saying, who's trying to call me? I'm not going to pick it up. So we had to work with our community mental health center and say, well, what we really need to do is to have you engage them when they're in hospital, or even one step before that, is that a lot of them were going to the ED. We looked at our data, so several of them were in the ED several times in the month before they finally got admitted. So what if we were to work with our community mental health centers and the care manager really goes and engage them in the ER the first time they show up. And if they do get hospitalized, engage them, build a face-to-face relation during the hospitalization, meet them at time of discharge, walk them to the behavioral health provider, get them into the additional services that are really critical for them to stay healthy, not just to see a doctor, but to all those other services that you guys are so great about providing. So I think as increasingly what we need to be able to do is get the data, but the data needs to be shared across a continuum. So too often what happens is the data sits with the MCOs, or the data sits in our electronic health records, right? And does it get shared? No. Do we actually get a consent? Do we really work very hard to get a consent to share the information? Probably not, right? Okay, so it doesn't get shared. And so there's a lot of data on these individuals that never gets shared, never gets analyzed, never gets used in a constructive fashion. That is a challenge for us as we go to managed care, is to say, how do we really improve the exchange of timely and actionable information? So if we're going to really improve the health of our communities, it's really about us understanding what do we need to do from a prevention standpoint. The next one, though, is I think a real challenge for us, which is acute episodic care. See, we love to blame our patients because they go to the emergency room for things that don't belong in the emergency room. Well, why is that? That's because when they get sick, they can't get in to get seen in a timely fashion. Or we set up other barriers. So you also talk to some of our patients and they'll sort of say, well, you know, it's much closer to go to the emergency room than it is to go to my PCP. I can get into the emergency room much easier than I can to, and then we'll blame them for calling 911 because that's their transportation to the emergency room. So we love to blame the patients instead of sitting back and understanding, you know, people do what they do for very logical reasons. It looks illogical to us because we don't understand why they're acting in the way that they are. But if they can't get in to see you, so, you know, if you're so booked up, I used to love when we started a health center, I love it, you know, we kind of arrived because we're booked out 4 weeks. There was no open access back in the 80s, okay? And we think, well, gosh, look how popular we are. Of course, I'm sure it was less than 50% because people would call and make an appointment. They couldn't get seen in a timely fashion, so they got an emergency room and never cancel our appointments. So we moved to open access. Is there open access availability within your behavioral health organization as well? Because it's really important. People can't always schedule when they're going to have a crisis and can they get in to be seen or not. So I think it's really an area that we need to improve both from a physical health and a behavioral health perspective. We need to understand the risk that our patients have and address those risks. And then we need to address so that their chronic conditions, whether it's behavioral or physical health, are well addressed, but also socially that we're addressing those issues as well. So it all sounds great, but what's the problem? Well, the problem is lack of data. Either that it's not getting collected, or more commonly, that's not being shared in a timely fashion. We also don't have the tools to support us. So again, as I mentioned before, being able to use that information when I'm actually seeing the patient is really important. But again, we need to look at our incentive system and the way that we get paid, because we don't get reimbursed for integrating our care, for having communication between our physical health specialists, let alone with our behavioral specialists. That takes extra effort, it takes extra time. It's not something that I get reimbursed for under a strict fee-for-service system. And then it's also about provider culture. So provider culture is that, you know what, for so long, it's like, I'm just responsible for this. I'm responsible as a PCP for the physical health condition and for mild to moderate behavioral health conditions. But when it gets to an SMI or an SUD, that's not really I'm not really accountable for that. Likewise for behavioral health, it's often like I'm accountable for this, and yes, I'm accountable for doing some screening in terms of the side effects that may come from some of the medications I'm using. But we have a culture where we don't really communicate and talk with each other very well and exchange ideas, and we need to change that culture. Fortunately, you guys in DC have access to CRIS, which I can tell you, because I'm in many states across the country, is that your HIE is much more advanced than most HIEs by far. In terms of being able to, most HIEs, I'm lucky to be able to get an APT alert in terms of knowing when somebody gets registered in the emergency room or discharged from the hospital. You guys have gone beyond that. I think there's obviously, I'm not an expert on CRIS, but I did do some work in Maryland and got to understand CRIS from that perspective. It is well advanced, but it needs to be used. And I think we need to take advantage of that. And again, as we're responsible under a population health, is we need to manage the full continuum of care and be accountable to understand where are our patients hitting the system and where can we take advantage of the information that is integrated within CRIS. And I'm sure CRIS will continue to evolve in terms of as a really important tool. So what are the information that I really need to do a good job of managing my individual patient and also understanding my population? So we talked about the ADT feeds. So you're going to see a couple of the quality metrics are about timely follow-up after someone's in the emergency room or being hospitalized for mental health. Well, I need to know that they were there in the first place. And so part of that is ADTs, part of that is getting authorization. Because when you look at your ADT fees, you don't always know exactly why they were in the hospital. Why they were in the emergency room, it's not always that apparent from the chief complaint that they put in at the time of registration. So it really talks about plan. If you're going to be responsible for managing and getting someone back in a timely fashion after an inpatient stay, and we're going to do that a little bit this afternoon, to kind of talk about, hey, how do we really perform on a couple of these metrics about timely follow-up. Well, that means that the health plan needs to have first attributed to know that you are the behavioral provider that they should be following up with in the first place. And then I got it because they did an authorization for that inpatient stay. They knew when that patient was discharged. Have they shared that information with you in a timely fashion? Do you have the discharge instructions? So it's really, this is the kind of thing where I'm saying that we got to have the multiple sets of providers, whether it's the hospital and the inpatient providers with the ambulatory behavioral providers and the health plan, to say, well, if we're going to really improve timely follow-up, and that is pretty clear that timely follow-up does reduce readmissions, well then are you doing a planning to make sure that you have it? Because for you, it's really frustrating for you to say, well, I'm being held accountable for 7-day follow-up or 30-day follow-up, and I didn't even know they're in the hospital. Just to be, how are we doing from a time perspective, is there's multiple sources of data, and some of that data you have, and some of that data the health plan has, and often the two don't exchange data, which means that increasingly what you're going to see is that the health plans are going to, with interoperability, start getting access to the information that's in your EHR. But once we have that information, is how do we do risk? So risk stratification now is based upon, hey, I have a couple of chronic conditions, or I have this, or I have that, but it's really not integrated. But what it really is, really moves to something that looks like this. So in Chicago, we're using artificial intelligence. I know artificial intelligence now is getting some bad rap, but there's a lot of positive stuff about it too. So if I need artificial intelligence to be able to tell me who is it that is becoming high risk, who's that emerging risk population, who's that high risk, because I only have a certain amount of resources. I'm delegated for care management, but I can't do the high risk care management on everyone. Who is it that's going to most benefit from me? So I need to be able to know, for example, that this person is becoming high risk because they have stopped taking their psychotropic meds. And I need to know that in real time, not 3 months later. This person has developed become housing unstable. They have developed diabetes from taking they've gotten overweight, they've developed diabetes from their psychotropic med. How does that information get integrated in real time so that we can identify who that rising risk population is and hopefully to intervene before they become high risk. Too often what happens with high risk care management is it becomes reactive when somebody is hospitalized. So what are we doing? So we certainly see the trend in terms of behavioral health. And we've done a good job of really now moving behavioral health from the sidelines to saying we're going to measure those behavioral health, and increasingly we're seeing those behavioral health metrics having financial implications as well. Let's just skip ahead. So let me talk about the 3 that are in the managed care contracts in DC. So one of them is screening and depression and a follow-up plan. Again, I think the trend will be eventually it'll get to be going from screening for depression follow-up plan to, hey, what happened to the PHQ-9? What percentage of your patients got their PHQ-9 less than 5? What percentage of them had at least a 50% improvement in their initial PHQ-9? But right now, we're making sure that people at least get screened. But then the other 2 are really follow-up for hospitalization after mental illness or after being in the emergency room. So it's in your handout. I'm not going to, or the slides have become available, so again, for time perspective, I will need some time for questions, as I won't go through but I think many of you are pretty familiar with those, and if not, I'd urge you, it's a little advertisement, come to Gene and my workshop, don't go to Josh's, go to our workshop this afternoon. But there are also a lot of other metrics that are not the ones that are, because there's only so many that the department can hold MCOs accountable for, and then in terms of you. But I think when we look at our quality of care, I would urge you as behavioral health providers to look at the other HEDIS metrics that are there specific to behavioral health, because ultimately these are the opportunities that when we look nationally at our performance on this and where there are opportunities to improve, it's many of these things. A lot of it is around medication adherence or really monitoring for the side effects of the medications that we're using. So I will leave you with that. So what about value-based care? So value-based care has been talked about for quite some time. As I mentioned, we got involved with it in 1987 in terms of value-based care, so it's been around for a long time. I think it has swung back and forth. It's back in vogue at this point, but I think it always made sense to us, because to me it sort of said is if you keep a population healthy, then there is a financial incentive to do so. Well, how do you keep a population healthy? The most important thing is actually improving access to ambulatory care, whether it's behavioral health or physical health care. It's all about, can I improve timely and accessible access to care? Because when I don't, people's conditions deteriorate to where they end up going to the emergency room, or they end up going to the emergency room because, you know what, I can't get in to see you as a provider, whether it's behavioral health or medical. So it really is moving in that direction. If you want to be successful with value-based care, the first thing you can do is look and see how difficult it is for patients to get in to see you when they need to be seen in a timely fashion. And what is the modality to do so? Does it always require that they come and see me face-to-face in person? I think we've seen during the pandemic that behavioral health, above all other things, telehealth is a good mode, and it reduces some of the barrier. You know, the show rates were much better with telehealth. I hope we don't go back to the day where we're requiring people to sit in our waiting rooms. I hope we don't go back to the day realizing that some of our patients don't have access to video-only telehealth, to sort of saying, as Medicare is doing, just so you're probably familiar, is they're requiring a video as well as audio. I think we saw for behavioral health that audio-only behavioral health worked as well. Obviously, if you can do video, that's great. There's a lot of visual communication that occurs, but if it's a barrier, then is that something like, so under value-based payment, particularly if I move away from fee-for-service, it's all about understanding how do I provide timely access to care, and also how do I use my full care team. There's a lot of things that can be done. So I heard you talking about the collaborative care model this morning. We rolled out the collaborative care model in Chicago, but we said, you know what, there's not enough behavioral health clinicians to do the behavioral health. There's not enough behavioral health clinicians in Chicago willing to serve the Medicaid population to do in-person counseling. But fortunately, CMMI tested something called a diamond model and looked at what if we trained community health workers in the collaborative care model, and what if they were the ones that were actually outreaching to those patients, and then they got escalated when the PHQ-9 is not improving or something else, it got escalated within the system. And you know what, when they tested the model, they found out that the patient satisfaction, provider satisfaction, PHQ-9 improvement was just as good when I used trained community health workers to be the initial outreach as if I used a behavioral health clinician. So why are we using Bay Health clinician? Because I need them to do things that they can do that I can't have a community health worker do. So when we implemented that model, it's been really successful in getting improvement in PH29. And then now what it says is that somebody's not improving. Those are the people that I need to then escalate to the rest of the care team, including the behavioral health provider. Those are the ones that need medication change or need more intensive counseling. So when they come to you with value-based payment, likely what will happen is they will pay you a fee for service, and they will focus on those 3 quality metrics. So you got to be ready for those. You should be looking at those 3 quality metrics. But you know what? That's really not where the money is, and that's not where the sustainability is, and that's not where the flexibility is in terms of you improving the care and using your full care team. That it really is moving now towards, hey, can I be contributing to managing total cost of care? Because if I do a really good job, what we'll be able to show, as I mentioned with that data, is I can reduce unnecessary hospitalizations, rehospitalizations, emergency room visits. That's where the money is, okay? And guess what? That's also where the bad outcomes are. The patients are not getting good care when they're having to resort to those areas. So if we can reduce that, which is to everyone's benefit, where's the money, where's the savings going? And so just to get to, that's where I really want to talk about. Can someone help me with that? It's showing there. It's showing up here?
It's shown.
Oh, good. It's just not showing on my screen. That's fine. Or moving. If you could help me for a minute for the screen. But the last thing I want to talk a little bit about is clinically integrated network. Is there someone that can help me with the computer? Yeah, okay. So what's happened with clinically integrated network is that for us to really manage a population is that we cannot do it as small individual providers. Even a single FQHC, which we did this for a while, is that the reason we formed medical network is that we needed to integrate together because there's investments in IT structure, there's leverage in contracting that can only happen with larger groups. And I think behavioral health, because they even tend to be often smaller providers, although there's large behavioral health providers, for us to individually sort of say, well, we're going to sign a contract and get a benefit from reducing hospitalizations, it's not going to happen. And so what you see around the country is behavioral health providers coming together and forming clinically integrated networks of just behavioral health providers, and I think there's a real advantage to that. But what we've tried to do in Chicago is to sort of say, well, what we really need to do is integrate behavioral health providers with physical health providers and come together within a system. And so I think the future for this for behavioral health providers is to go beyond their own IPAs, to integrate with the physical health IPAs that are there. And then you are responsible, just as we are now in Chicago, for total cost of care under global risk contract. So under that flexibility, you can start to look at your data because you're actually sharing data between the behavioral health provider and the physical health providers. You have aligned incentives to improve patient outcomes, but you also can make focused investments. So one of the things we did recently is we looked at our data and we realized that we had a group of individuals that predominantly had a behavioral health and SMI type diagnosis, and they kept going into the hospital. A lot of them had comorbidities. Like I'll tell you one gentleman, which he was hospitalized multiple times for his congestive heart failure or for exacerbation of his schizophrenia. And then we started to talk with him. We realized that he was homeless. That what he would do when weather was inclement is he would jump on the L, and there's a train that runs between Midway and O'Hare, and you just go back and forth. And that's how he got out of the elements. The only problem with those trains is there's no washrooms. So guess what? When he would take his diuretic for his congestive heart failure and there's not a washroom, he became incontinent. So what did he do? He stopped taking his diuretics, he would get fluid overload, he'd get hospitalized again. And we were spending well north of hundreds of thousands of dollars on him and he's having bad outcomes. So what did we do? We ended up saying, well, we've generated savings. This is what Director Bird mentioned, is we had more flexibility in how we spent. So we took our money and we spent for him to get in the flexible housing pool and to get housing. And we found other individuals like that. It was made much more financial sense for us, as well as the right thing to do, to spend money on getting him in housing. And guess what happened once he got housing is his hospitalizations went down. So it's really, that happened because we were integrated, because we had the community mental health centers kind of addressing this issue, physical health, but we also were looking at the social drivers of health. So I think the future for us is to be able to say we're integrated delivery systems, we're accountable for total cost of care. Let's make logical use of the resources that we have. And sometimes that's going out of the traditional medical system. So I will stop at that point and, gee, how much?